So let's take a look at the arteries. Arteries are going to function underneath positive pressure, which means that there's pressure pushing in on the fluid and pressure of the fluid pushing back on the lumen itself. The lumen itself is lined with epithelium. Outside the epithelium is the muscular um, ring, sometimes referred to as the muscular wall. It's this muscular ring that produces the positive pressure inside the arteries as it constricts in order to produce positive pressure within the lumen itself. In the most internal part, in the tunica interna, there are ridging or folds. These ridging and folds creates an irregular shape within the lumen that allows for expansion and contraction or constriction of the lumen without rupture, either to change direction of flow or to allow for flow of fluid through it via intermittent pressures. If we look at the arteries, there are three distinct types of we usually talk about. These three distinct types of arteries that we usually talk about are the elastic arteries, which are usually the larger arteries. The larger arteries have not as much tunica media as the muscular arteries do, but what they do have is they have within this muscular region of the tunica media a large amount of elastic fibers. What this does is this allows for a large degree of compliance to occur, to allow for a stretch and contraction of the artery during the volume changes that occur with systole and diastole of the ventricles. These elastic arteries allow for a continuous flow of fluid even though we have intermittent pressure as we have the contraction cycle occurring within the heart. The muscular arteries are the arteries that are going to be distributing flow from the elastic arteries into the organs and into the tissues. These have a larger amount of muscle within the tunica media and a less amount of elastic fibers within the tunica media. They typically are going to be involved with the vasoconstriction and vasodilatation regulation of peripheral resistance due to ANS signaling, nervous system signaling, as well as bradykinin and kinogen signaling in an attempt to regulate peripheral resistance. The last type of artery that we see is the arterial. The arterial is much smaller in terms of muscularity relative to the other two arteries. There typically is no tunica externa here, and the tunica media becomes a little bit less robust, meaning there's less muscle there, and intermittent within the arterial itself. The arterial itself is going to control flow going into the capillaries via sphinctering, closing off of the arterioles. This sphinctering, or this controlling of fluid into the capillaries, is based off of internal signaling, bradykinin, kinogens, paracrine, and autocrine factors, as opposed to ANS signaling, causing the vasoconstriction and vasodilatation. The next type of vessel that we have to worry about are the veins. Unlike the arteries, the veins function underneath negative pressure, meaning that the actual vessel itself does not produce pressure onto the fluid, but the fluid is producing pressure back onto the vessel. It's the fluid pressure within the vessel that keeps the vessel from collapsing. This is where when you take a blood draw, you have to worry about collapsing of veins, because if you change the fluid pressure within a certain area, the vein will actually close in on itself because there's no actual internal vessel pressure occurring. The only pressure that occurs is from the fluid. The vessels themselves are typically smooth walled, meaning they don't have the ridging that we saw with the arteries, which means they're not going to open and close as we saw with the arteries. In order to correct for this not opening and closing, the veins have valves within them, as we saw earlier, that prevent the backflow. Just like with the arteries, there are three distinct types of veins that we should be worrying about. We're going to start with the tissues and work our way back to the heart, where we start with the venules. The venules are basically the veins that are going to be connecting the capillaries back to the other veins on the venal side of flow. They're typically very small, 50 microns in diameter, and typically lack any tunica media. In some venules, there's intermittent tunica media, and we call these muscular venules. These are the venules that will regulate flow through the tissues based on bradykinin, kinogen, autocrine, paracrine signaling with the arterioles in order to change where flow of blood is going. The next type is the medium-sized vein. The medium-sized vein will have a limited amount of tunica media with very minimal amount of smooth muscle. Most of the tunica media here is elastic and collagen fibers. These are larger in diameter than the venules and lead into the large veins. The large are typically the great veins or the tributaries that lead to the great veins. These are the veins that we typically see if we examine the body. We usually don't see the medium-sized veins. We usually only see the large veins or the great veins. These have some tunica media, but comparing it to the other tunicas, it's much less robust. In fact, the most robust tunica here is tunica externa. The tunica externa in the large veins lack vasorum that is present in the arteries, which means that it does not get nutrient flow and leads to the cyanotic hue of the veins that can lead to that misconception that blood is blue, which we talked about already. The last type of vessels are the capillaries. The capillaries are single-celled tubes or single-celled lumens. The reason for the single-cell issue, meaning there is one epithelial cell on top of a basal membrane, is to maximize the rate of diffusion. The rate of diffusion is inversely proportional to the distance that it has to travel. Most of the capillaries are very small in diameter, 3 to 4 microns in diameter, and can range up to about 30 to 40 microns, depending upon the type of capillary that we're looking at. There are more capillaries in terms of distance than arteries, arterioles, venules, or veins in the body. The body can regulate where flow is going in terms of into or out of these capillaries by shunting at anemostis or collaterals within the tissues. In general, there are 3 distinct types of capillaries. We break them up into what are usually referred to as the sinusoidal capillaries and the fenestrated capillaries. Within the sinusoidal capillaries, there are 2 distinct types. There are the continuous and the discontinuous. The continuous have no gap junctioning occurring whatsoever. It's strictly tight and desmotic junctioning between the epithelial cells, and there is no gap in the basal membrane whatsoever. The continuous sinusoidal capillaries allows for material exchange via diffusion only, which means that these are only small molecules or lipid-soluble molecules that can diffuse across the cells and across the basal membrane. Whereas the discontinuous has tight and gap junctions occurring, along with gap junctions forming within the basal membrane. This allows for regulation of materials, but allows for slightly larger materials to diffuse across the cells. The last type is that fenestrated capillary. The fenestrated capillary has a discontinuous basal membrane, pores that form within the cells themselves, and gap junctions between the epithelial cells. What this does is this permits all large materials, usually any material that is smaller than a red blood cell, to pass through the capillary and pass through the basal membrane. This allows for larger amounts of diffusion to occur, as well as larger molecular weight molecules to occur. In some fenestrated capillaries, we can actually form sinuses within the basal membrane that allows for collection of materials within the capillary network itself. In the capillary network, we usually talk about it as being a capillary plexus. The capillary plexus is the connection of blood vessels allowing for flow between the arterial and the venule side of the cardiovascular system. It allows for and regulates flow in and out of tissues, and the regulated flow develops the collateralization and anastomization of the blood vessels based off of what's usually referred to as angiogenic signals, meaning that we're going to form new blood vessels in regions where we need to increase blood flow, and we're going to decrease capillaries in regions where we diminish blood flow. If we look at this capillary plexus, this is what we're looking at. Sometimes the capillary plexus can be referred to as a capillary bed in layman's terms. What we're looking at is we're looking at arterioles that are going to form into a single branch. This arterial branching is the collateral flow. The collateral flow allows for directionalization of flow into the tissues based on metabolic demand and forms what is usually referred to as the cardiac shift in terms of response of cardiovascular flow due to metabolic demands. Now what ends up happening is that we have anastomotic junctions that allow for certain areas to be bypassed, meaning areas that have low blood flow or low need of blood flow. They're not metabolically active. We can actually bypass that. At the junction points within the arterial to venule side where the capillaries form, the junctions to the arterioles are controlled by muscular sphincters, basically circular rings of muscle that can be vasoconstricted or vasodilatated to either decrease, vasoconstrict, or increase, vasodilatate the flow through the area based on metabolic demand. When we have to bypass areas, we use an anastomotic junction, a junction that basically does not form a capillary network or a capillary plexus in the tissue. As tissues become more metabolically active, there is a greater angiogenic signal. We get larger amounts of collateralization, splitting of the arterioles into new arterial, as well as anastomotic junctions, leading to more capillary beds within the tissue. These are the angiogenic signals that increase total vasculature in the body. We do not make more arteries, we do not make more veins, but what we make are more arterioles, more capillary beds, and more anastomotic junctions that increase total amount of flow.